Okay, now we're beginning to move into your pediatric book content. Hydrocephalus is increased production or impaired absorption or a block in the flow of cerebrospinal fluid. This results in an excessive amount of cerebrospinal fluid within the cerebral ventricles. 1 in 500 children are thought to be affected. It can be an acquired congenital disorder, or it can be of an unknown etiology. There are basically two types, communicating and non-communicating. Hydrocephalus, when it is communicating hydrocephalus, that means that there is an obstruction outside the ventricular system that is causing a decreased absorption of the cerebrospinal fluid in the subarachnoid space outside the ventricular system. Now, it is a non-communing hydrocephalus when the problem is responsible for non-communicating hydrocephalus is going to be responsible for most of the occurrences when hydrocephalus is occurring in children. It is caused by an obstruction of the cerebrospinal fluid flow that occurs within the ventricular system. Most often this is secondary or due to a congenital malformation. Now, this is going to be listed for you in greater detail on in chapter 32 of your PEDS book. Hydrocephalus begins on 1206. Hydrocephalus as neonate and early infancy is regarded as primary dysfunction caused by either intraventricular hemorrhage or structural defect. Hydrocephalus in children and adolescents develops most often from intracranial tumors, infections, or head injuries. That causes the signs and symptoms of increased intracranial pressure as well. Most often an increase in temperature that is not responsive to being given an antipyretic pharmacological measure is accompanied by a decrease in respirations. That's one of the signs for your children and adolescents, is the increased temp that does not respond, accompanied by a decreased respiration. Clinical manifestations: enlarged ventricles resulting from trapped cerebrospinal fluid leads to compression of the brain parenchyma against the skull and increased intracranial pressure. Figure 32-6. During neonatal period hydrocephalus, it is common with meningomyelocele at the thoracic and lumbar junction or above. If this defect is not immediately apparent, then the only sign of the disorder may be a rapidly increasing head circumference. Within 2 to 4 weeks of life, the measurement may be as much as 1 to 2 deviations above normal size. The head will be disproportionately large in comparison to the face. With few exceptions, treatment is going to be surgical. It requires removal of the lesion and the insertion of a shunt. Figure 32-6 in the pediatric book. This gives you an idea of the size of a normal and then a hydrocephalic head circumference. The brain scan comparisons of the normal cerebral ventricles with those of excessive cerebrospinal fluid accumulation in the cerebral ventricles. infant with hydrocephalus, all of these symptoms on the slide, the visible sclera above the iris, the term for that symptom is sun setting sign. Also a positive McEwen sign. What that is a hollow or a cracked pot sound that is produced when percussion of the skull is initiated. Neurologically, this infant is most likely going to be fussy and restless, irritable, apathetic. They may even experience altered or diminished level of consciousness that is accompanied by sluggish pupillary responses or posturing, atypical reflex reaction, lower extremity spasticity. In addition to this, the infant may feed very poorly because of the difficulty positioning, difficulty swallowing. Their cry may also be noted to be very high-pitched in nature and cat-like in some extreme cases. Also in extreme cases, cardiopulmonary depression may occur. In an adolescent with hydrocephalus, the symptoms listed on the slide, the hydrocephalic older child or adolescent, they display no enlargement of the head. Instead, most of their signs and symptoms are those consistent with what you see in increased intracranial pressure. Upon awakening in the morning, the child may complain of a headache, may experience nausea and vomiting, irritability, lethargy, apathy, confusion, impaired judgment and reasoning skills. The child may become incoherent. There will also be a change in their motor abilities. Some examples would be ataxia or spasticity. Papilla edema is the swelling of the optic disc. Strabismus or decreased visual acuity may be the result. The shunt system is going to be made of a radio-opaque plastic material that has a ventricular catheter, a unidirectional or a one-way directional pressure valve, and a pumping chamber, as well as a distal catheter that will work all together to direct the flow of cerebral spinal fluid from these ventricles into other areas of the body so that it can be absorbed. Shunts will manage ventricular enlargement and help manage the increase in intracranial pressure. Now, most often in your pediatric patients, the shunts are ventriculoperitoneal. That means that it's going from the ventricles into the peritoneum. On page 10, figure 32-8 on page 1211 is a picture of the ventriculoperitoneal. There you go, ventriculoperitoneal. And there's also another kind of shunting for this increased fluid, ventriculoatrial, which means it's being shunted from the ventricle to the left atrium. This is your ventriculoperitoneal shunt. Just a description, again, that is on page 1211, figure 32-8 in your pediatric book. Shunting will play a big role in trying to correct this hydrocephalus and some of the neural tube defects that we will be discussing as well.